Mama, I got bad news, bad news. I've been rolling with some bad dudes, bad dudes. I've been trying to get a bag.
Hello, listeners. Welcome to the Ashes to Awesome podcast, Rising in Recovery. Our podcast provides light, hope, and understanding about addictions and mental health to people living within that life and the people who love them. Today's episode is brought to you by Yacha Treatment Centers in Phuket, Thailand. They are a clinic run by clinicians, not a business run by businessmen. And they know that where addiction is the smoke, trauma is the fire. Learn more at yatracenters.com. That's yatracentre.com. Hello, everybody. Watchers, listeners, supporters of all kinds. Welcome to another episode of the Weekend Ramble on the Ashes to Awesome podcast. I'm your host, Chuck LaFlange. With me in virtual studio is my lovely co-host, Attica J. How you doing today, Attica?
Hey, I'm good. I have my uppers. How are you, Chris?
I am fantastic. It's midnight here in Thailand, and I just drank a triple shot of coffee. So soon I'm going to be here in colors, right? That's where I'm at. And we have a special guest with us today from Vancouver, BC. He's a physician with a long history in harm reduction, including the first person to prescribe prescription heroin back in 2006. Please welcome Scott MacDonald. How are you doing today, Dr. Scott?
Doing well here. Glad to be here.
Good stuff. We're glad to have you. What I like to do right out of the gate here, Scott, is to kind of get a feeling for why you're here at all. Why don't we let the listeners understand, what you're doing here and what your history is and what gets you to a point where I want you on the podcast.
I'm a general practitioner in Canada. I began my work as a physician in the Canadian Navy, was the base addictions officer at CFB Halifax. Sort of saw everybody that was coming through the military with struggling with substance use, mostly alcohol. And we ran a little 28-day inpatient facility at the base. And certainly most people did really well, right? Led to recovery.
Yep.
But not everybody.
Okay.
Some people said,
"Can I ask you, sorry to interrupt, just for some context, when would that have been? Like what year?
92 to 96. So about 30 years ago.
Okay, great. That just gives us something to frame what you're talking about. But please continue. Yeah, please continue.
But some people said, I don't care about your military. I'm going to drink. So I'm out of here. And I had nothing to offer those folks. I had nothing to motivate them. So I wound up a few years later in Vancouver. Spent the first couple of years working at a methadone clinic, and again the same thing. Methadone worked really well for some people, but some people said, "I'm not interested in that," and continued using heroin. And heroin was the sort of the opioid that was available at the on the street then.
Okay.
So there was a group there that was starting the NAOMI Project, North American Opioid Medication Initiative.
Okay.
And they were that was the first North American study looking at prescription heroin. It was asking the question for people that continue to inject that haven't been motivated into care with the methadone or the standard treatments, then is heroin or diacetylmorphine an effective treatment option? And they came to me because they had trouble recruiting doctors to be part of the prescribing group of the clinic. And I said, well, that sounds interesting because, methadone's great, but it doesn't work for everybody. I agree. We need to look at other options. That study ran from 2005 until 2008, was published in the New England Journal of Medicine. Yeah, prescription heroin is superior to methadone in that population that continues to inject. But we weren't able to transition to a program at that time. Health Canada would not allow us to have access to the medication, the diacetylmorphine, and we couldn't find anybody to pay for for a program, so that it just kind of folded. Denmark, though, looked at the results of our Canadian data and said, well, we're going to open a a treatment program. And Denmark has had prescription heroin since 2010 integrated into their healthcare system based, well, in part on our Canadian data. But it led to our
Really?
follow-up study.
Okay. Continue. Yeah.
And 10% of the people who were receiving injectable treatment in NAOMI, the first study, were actually receiving hydromorphone or
Okay.
Dilaudid, a common painkiller and analgesic. Most people know what is Dilaudid, right? And
Dillies is what we call them on the street. Yeah.
Dillies, exactly.
Dillies, we call it Dillies.
Yeah.
So, but what was surprising to us, the folks that were receiving hydromorphone blinded in the study, even though they had on average like 21 years of injection experience, couldn't distinguish which drug they were getting, blinded, and
Really?
the treatment effect was preserved. This is blinded in a controlled study, right?
Yeah.
So that led to the question, well, if we can't get diacetylmorphine, if there's too much stigma and regulatory barriers around providing diacetylmorphine to prescription heroin, maybe if Dilaudid's an option, then it might be worth considering because it doesn't come with the same century of stigma, right? So
So if I can ask from a medical perspective, the difference, just so that there's some clarity for the layman here, myself included.
Both molecules are very similar to morphine. So heroin diacetylmorphine is like morphine with two acetyl groups on it.
Okay.
Hydromorphone is like morphine with a hydrogen and an oxygen group on it. Very similar molecules.
So to the layman, what does that mean? So my job typically is to dumb things down for the audience. So that's
so they're very similar molecules. They're short-acting drugs. They might give some euphoric effect, but every molecule is subtly different. So you don't know how it's going to work or what side effects it might have. It needs to be evaluated to see if it's safe and effective.
Okay. So now where are we at for a timeline in all of this?
We're now up to 2011.
2011. Okay, so it's still some time ago. So now what's happened since then, Doctor?
So we ran that trial from 2011 to 2014. Yes, hydromorphone is as good as diacetylmorphine, and published in JAMA Psychiatry in 2016. But we were able to transition to a program after that trial.
Okay. And that was just in British Columbia or elsewhere in the country?
Just in British Columbia.
Okay. Is that the program you're currently working on, or is that evolved now as well?
That's where I'm currently working. Although there are clinics like ours in about half the provinces in Canada.
Okay.
And we have both prescription heroin and hydromorphone. Hydromorphone was a little bit easier.
How does that happen then? How did that come to be? How did you end up with prescription heroin as well?
Well, it is a story. It wasn't it wasn't easy.
That's what we're here for.
But when people were getting ready to leave our second study, the Salome study, because it was a 1-year program, but we saw people benefiting from the treatment. They're engaged in care. Their lives are more ordered. They have an alternative to the street supply. So we want to be able to continue it. So we started applying to Health Canada for access to diacetylmorphine, even though it's not approved yet in Canada, through what they call the Special Access Program, or SAP.
SAP, yeah.
Okay.
And although they wouldn't give us that approval during the first trial, we now have that Canadian data showing evidence, and we have a Cochrane review showing that there's efficacy, that diacetylmorphine has value. And Cochrane is sort of the gold standard agency that reviews evidence-based care in medicine. So Health Canada really had no choice but to approve it.
Is it? Because of the Cochrane.
Because of the evidence, and the bureaucrats at Health Canada just look at the evidence for efficacy and safety, and we also had cost effectiveness data at that time.
Okay.
But
go ahead.
it
go ahead.
still requires political sign-off.
Yes.
The Minister of Health would need to sign off on that approval, or so
that's an uphill battle.
the then Minister of Health was a conservative government under then Stephen Harper was the Prime Minister.
Yeah.
And his health minister was someone by the name of Rona Ambrose. So
Yes, I
Minister
remember her.
Ambrose, on the same day that we got the first approvals, stood up in Toronto and said, well, this is against the policy of our government. Some of the bureaucrats in my office have undermined the intention of the government and gone rogue. We're not about putting heroin into the arms of addicts, and we're going to reverse this decision and make sure it never happens again.
Okay. So what happens from there?
Our Providence Healthcare, the province, Pivot Legal, the patients in our study were really upset by this because there are people who are benefiting from a treatment in a study. They have a right to continue to access something that you're benefiting from in a study through what's called the Helsinki Accord, to which Canada is a signatory. So all those organizations took the federal government to court, and we won an injunction in the BC Supreme Court, a decision by Chief Justice Hinkson, allowing us to have access to diacetylmorphine under the conditions that existed before the Minister Ambrose intervened. So we were able to get diacetylmorphine, and the first treatment with diacetylmorphine in Canada happened in November of 2014. We've been a program ever since, offering both hydromorphone and diacetylmorphine. We now have a domestic producer of diacetylmorphine and prescription heroin in Montreal, so we're no longer importing the Swiss product. We're using a Canadian product since 2019. And the next thing probably for injectable is to add in sort of a fentanyl related product, which we're not doing it at our clinic, but other clinics in Vancouver are looking at.
So how does one get? So if I'm a participant in this program, how is it decided which route I'm going? Whether I'm going the dilly, if you were, the hydromorphone, or the Dilaudid, sorry, or the prescription heroin? Like how is that decision made?
Well, I guess it really depends on what clinic you go to, but most clinics that are offering this in BC have access to both. So it really is patient choice. What do you prefer? And if you try one and you don't like it, you can try the other.
Yeah.
Both of them have indications for treatment of opioid use disorder in Canada.
Now, stacked up against the new reality of fentanyl, how do they perform relative to when it was heroin and really, I guess hydromorph was kind of like it went from heroin to hydromorph to fentanyl. Best I understand from my perspective as a street level kind of person,
right?
It's what the common drugs were. So how does it perform now in the new reality?
Well,
or is that
the BC Center, British Columbia Center for Disease Control, did a poll of people using street opioids in 2019, and at that time, the plurality of folks, although they were accessing fentanyl, were still seeking heroin. The retention in our first trial was about 90%. Remarkable.
Wow. Guys, I just wanted to take a quick minute and let you know what's going on with me out here in Thailand. So I came out here for a scholarship to attend a trauma treatment, and it's going really, really well. Really well. I'm going to be getting my own place here. Well, I've got my own place. I don't technically move in until the 12th, but it's all squared away and all that now, so I'm super happy for that. And I do have a GoFundMe going, and as much as I hate to ask for help, I have been asking since just before I left Canada to come out this way. It's not a lot of money in this game, and I'm trying to make a go of it alone. This will be the last month that I'm asking for help, and I do have a GoFundMe page there. The link is down at the bottom of the screen here now. anything you can do, $5, $25, $100, it could change my life, right? And what that does is it helps me to continue spreading the message in a sustainable way and all that stuff. So I've been working really, really hard at this podcast for a year. I'm really happy to say that, you know, the move to Thailand has put me in a place where I can continue to do that, because back home it wasn't sustainable anymore. The cost of living has just gotten too high. And but I could really use a little bit of help just this last month. So if you've got it in your heart to give, I really do appreciate it. And remember, you are loved.
And in a follow-up study, nearly as good, sort of 80% plus. But you're right. Since the street opioid has changed to fentanyl, it's a little more challenging to engage folks. But our retention is still pretty good.
Okay. Can you tell me what pretty good means? What's the number?
60-70%.
Okay, if it's effective at that rate, right? I mean,
and we do better probably with people that are a little older who've had experience with
heroin.
Yeah, I can imagine that. Yeah.
But some young people also try it and say, "Oh, yeah, this is pretty good." But I think that if we're really going to get everybody into care, we are going to require a sort of a fentanyl-based option.
Which is something we've recently discussed on the show, and something actually Attica got quite passionate about when we were discussing it, was the need to kind of introduce a fentanyl component to things, instead of trying to give fentanyl, people that are suffering in a hard fentanyl addiction, a drug that just doesn't compare. You know?
Yeah, it's just because I think there needs to be more options, that it's not just Dilly's hydromorph, but there are people who like diacetylmorphine heroin. There are people who like benzo. There are people who like, different things. Fentanyl, usually younger people, they like fentanyl because they never tried diacetylmorphine heroin before. But when they're like really old, usually, they try.
I got to ask you, what does really old mean?
I don't know, Chuck. How old are you? No, I'm joking. Oh, shoot. I'm going to be kicked out from here.
And that was Attica's last day on the podcast.
But there is something to age. The folks in our clinic are a little bit older, with an average age of around 40.
Okay.
And mostly male. But the folks that come into our last study, on average, had been using for 15 years and had 11 attempts at treatment. That speaks to a couple of things. That the folks that come for this treatment need this treatment. They've tried everything else, and they've been using and been at risk for a long time. But it also means, I think, that we're setting that the barriers to get into these kind of programs is too high. Why are we waiting until people are 40 and have had decades of experience and struggles and trying other treatments and nothing has worked?
And also, Scott, it seems like, the older and the longer that we wait until to get them into the prescription medications, they would have had ODs multiple times, especially male, and they try the street supply, and then they could have had poisoning, like lots of poisonings, before they can get into your care.
It's a lot of brushes with death. That's what that is. That's what I hear when you say that.
Yes,
it's a lot of unnecessary brushes with death. One could argue, certainly. Right? There's so much to talk about here.
And we do offer some fentanyl. But the fentanyl that we are providing is the fentanyl patch.
Okay.
Which technically, when I prescribe it, it's called safer alternative or safe supply. So it doesn't have an indication for treatment yet. But it's a slow release product, so it's not going to give people a euphoric effect or some kind of a high if that's what they're seeking. But it still is a fentanyl product, and it seems to be, even though it's long acting, sufficient to attract and retain some people in care.
And I would think that when somebody gets to a point, from my own personal experience, you get to a point when you're speaking about the demographic here with the older CC. Now I'm like really aware of that statement, Attica. When you get to older people, there's this sense of exhaustion, right? And again, that's very anecdotal, and it's my own experience. But it's like I've just had enough. So if you can give me something that isn't going to get me high, but I'm not going to get sick, maybe that's enough for me. But for somebody who's young and hasn't had to grind that out in such a horrible, long, stretched out way, maybe it's not quite as attractive for them, right? I'm just guessing. I'm just guessing.
Well, and there was a study out of the U.S. called the POTS study, the prescription opiate study. They took folks who'd been using as little as 8 weeks of injecting opioids and randomized them to receive a tapering prescription of Suboxone.
Okay.
And basically, it after 8 weeks, if Suboxone was tapered, everybody relapsed.
Yeah.
And as little as 8 weeks of injecting, and you're looking at a long-term chronic problem.
Yeah. Well, and we know it doesn't take much, right? We know that's for sure. And especially now with fentanyl, I'm no doctor. I understand that it is a much more addictive product, and a much more it's just much harder to get away from, right? I guess that's accurate, right?
I'm not sure that it's more addictive, but it's more potent.
It's potent.
And it can be produced inexpensively and easily. So suddenly it's readily available anywhere and everywhere. Highly potent.
Right. You know, when I years ago, when I was still in active addiction, I was arrested with a significant amount, and at that point, fentanyl was going for about $4,000 an ounce on the street level, and now, as I understand it, it's under 1,000. So it speaks to, you know, and that was only 4 years ago, right? So in that time, during COVID, actually, during the shutdown, all the other street drugs went up in price, doubled, tripled, quintupled for meth, for instance, at street level. But fentanyl just kept coming down, right? It dropped throughout the entire lockdown, right? So,
and it seems like we now have a situation with carfentanil, which is even more potent than fentanyl, with a little dose that is just like you know, pretty much like a dot. You know, that it's enough to quote unquote OD someone, and like that's why I don't really like to use the term overdose. It's not really an overdose when you don't really know what's inside of the batch. And I'm talking about the street. Yeah, it's poisoning.
Right, yeah. And speak to the stigma on that. Ryan and I talked about it on a Wednesday episode. Nobody ever called it an alcohol overdose when somebody went.
Right?
You know, when we were kids, it was an alcohol poisoning. So it's pure stigma that we call it overdose over poison. Right?
I think so.
Yeah. And the most disturbing thing for me is we call it an overdose if somebody's a little bit drowsy after they take the medication, or if they're dead.
There's a perspective I haven't heard. I like that.
Yeah.
I do see that. I shouldn't say I like that, but
nodding off is not an overdose. It's just
no. Yeah. Right.
That's true.
No kidding.
Yeah.
No kidding. Geez, so much to take in here. So the stigma, it's got to be very different now. I would hope it's very different now than it was back in the Ambrose days. So if we want to refer to it as that, as far as what it's like to get approval and funding for this. Have you seen a shift that way, Doctor?
In Canada, not much.
Really?
We put about in our NAOMI study, and then over 200 people, over 250 people had access to prescription heroin during the study. In all of Canada today, I think there's less than 250 people who have access to prescription heroin. So there may be some, and some legally, but if you look at the numbers, the number of people that have access to it, it's pretty grim.
Wow. So relative to how many people have prescription to Dilaudid, How does that
Relative to other people
have
who
access to it?
might benefit from a treatment like this. In British Columbia, for example, there's probably 100,000 people who would meet the criteria for moderate or severe opioid use disorder.
Okay.
And it might be 10% of those folks who might meet the criteria for an injectable treatment option. So even BC alone, there might be a need for 10,000 people receiving something on the harm reduction end of the continuum like this. And I say that somewhat disparagingly because there are other countries in Europe like Switzerland, Denmark, Germany, the Netherlands that have managed to integrate treatments like this into their healthcare system, have diverse options for care, and do not have epidemic substance use or street drug poisonings. So we're not we're doing something here in North America and in Canada, but we're not meeting the standard that some of our European colleagues have met.
That's a really interesting thing to me now in a way that it wouldn't have been a couple months ago. Being here in Thailand at a treatment center, most of the people here are from Europe, right? Because it's just the reality of it, right? Geographically. And in speaking to them, we don't have what you guys are dealing with in North America. It's like, well, it's only a matter of time. And they just don't. And to me, it's like, well, of course, eventually it's going to come to you, but maybe not, right? maybe that's why I never even considered that, right? That, doing such a, I'll say, better job of treating this opioid use disorder, and maybe it doesn't get to a point that it has in North America, right? I always assumed that it would eventually, but perhaps I'm wrong.
Right? There's also geography, so you can
cartels and
you can import heroin fairly easily into Europe, and there's more barriers for heroin producers. So but that's probably in some ways that's driving the potency and the possibility of poisoning in North America, and it is a failure of regulators and governments and society to respond accordingly and provide a regulated, safer alternative.
Yeah, right. And I'll tell you. Go ahead, Attica.
So, Scott, I know, we talk about comparing and contrasting the Portugal model. How would you, but, the audience doesn't know that. So how would you compare and contrast the method that that they've been doing in Europe, in the Netherlands and the UK, Denmark, versus Portugal? How is it different?
I think first we need to explain what the Portugal model is, what's happened. So if you could do that first.
So I'm not an expert in the Portugal model, but as I understand it, they've gone there's sort of three things that sort of decriminalize. So don't criminalize people who use substances. Don't arrest them for possession. But that's not unique to Portugal any longer. The other thing they've done well is make it easier to get treatment. So they don't have prescription heroin, but they've made Suboxone and methadone and sort of used like mobile pharmacies and ways to make it easy for people to get their medications and prescriptions, so that they don't have to go all the way across town or leave places of employment. So they really support people to take their medication and be in care. They also have sort of panels that support people. So if you want to be able to work or do some part-time employment or get housing, they'll support people to do that. I think those are all sort of important things, and other jurisdictions have done that to some extent. What we've done in BC, they've recently gone to some decriminalization, but that hasn't followed across the province, and it's still we haven't done the work to make it easier to get into care to diversify how people can access medications. And many of the patients at our clinic, many of them do find work and employment, but they're doing that on their own. It's the society's not there like they are in Portugal to have supportive work programs, supportive volunteer, those sorts of things. So those,
now,
I think
for
that
a quick public service announcement. One of the best ways to reduce stigma is with education. If you still have questions that we haven't answered on today's show, you can learn more about Together We Can's education group at twcrecoverylife.org.
Hey everyone, this is Ryan Bathgate from Kaleidoscope Wednesdays. I wanted to bring a public service announcement to you today about Narcan, or also known as naloxone. These kits have saved so many lives over the years. I can attest for that. Being in the industry for so long, I can tell you since we've had the opioid crisis declared in 2016, it has saved thousands of lives, and I've watched it personally save hundreds of lives. These kits are small, easy to use. You can keep them in your glove box or in a cupboard in your home, and you never know when somebody's going to need them. If you have a hard time finding a Narcan kit in your area, just email us here at ashestooawesomepodcast@gmail.com. Throw Narcan in the subject line, tell us where you are, and we'll do the legwork to find that for you. If you wanted to send me a question for my Kaleidoscope Wednesdays, again, email ashestooawesomepodcast@gmail.com. We will read that question on air, and I'll do my best to answer it in a comprehensive way. That's all I have for now. We'll go back to the show. Thanks for listening.
So those, I think that those things are important things that Portugal is doing that maybe we should look at here.
Yeah, right. I was recently reading an article about how in Portugal things are kind of falling off now. And I was like, okay, maybe it doesn't work long term. But then, of course, the rebut to that article was, but the funding has been slowly tapered off as well. So some of those supports
Portugal
aren't there the way they
model,
were, right?
what I'm seeing is that it lacks options for people who are already at the severe opioid use disorder, that their only option would just be given a prescription heroin. So it's like decriminalization alone is not enough. There needs to be a decriminalization and then regulation on the supply on the streets, and make sure that everything is clean and not, tainted and not laced. I think that sorry, Scott.
And Portugal does not provide prescription heroin. So it's
exactly.
If we're just talking about opioid use disorder, they've certainly optimized and diversified how people can access methadone and Suboxone, those sort of long acting medications. But for the folks that require something that still has a euphoric effect, then they've not gone down that route yet.
Okay, see, I was under the impression they had. So thank you for clarifying that. Yeah, okay.
But other places have, like Denmark and Switzerland. Switzerland probably has the most experience. Denmark, I mentioned them earlier. They looked at the Canadian data and said, we're not going to do any more studies. We're going to integrate prescription heroin, and have done so since 2010. They just published a paper in the last week on December 2nd of this year.
And what are the results there? So how's that looking?
They have they've found that there's the people that come in to prescription heroin have some unique features. They, compared to people who are accessing methadone and Suboxone, they've had more admissions to hospital, more injection drug use, and more criminal justice involvement. Which isn't that surprising, but those are folks that a government should be looking at trying to get into care, right? The other thing that they've noticed is, over time, the people enrolling in all opioid medication treatments in Denmark is going down. So it seems like they've addressed the problem to some extent. And The number of people receiving injectable treatments, heroin-assisted treatment, is stable at 4 to 10%. So it's a small number, a significant group that we as a society should be offering alternatives to and getting into care. But there seems to be a worry in North America that everybody's going to start and want prescription heroin treatment, but that's just nonsense. The people that come for this kind of treatment need this treatment.
Fair enough. Do you have a response to critics about the diverted supply in these programs, or in your experience, are they supervised? I should say, actually, we'll talk about that first, right? So,
well, that brings me to that's a good point, because up till recently, all of our prescription has been supervised.
Okay.
Interestingly, though, the first country that did prescription heroin was England.
Yeah.
And their model has been for over a century a take-home model, unsupervised.
Really?
So,
okay.
So in England, there's several hundreds of people who go to a pharmacy. They pick up powdered heroin, sterile syringes, packets of sterile water. They go home, compound that themselves over the week for their prescription, and then they go back to the pharmacy in a week and pick up their next supply.
Okay, and how's that program work? Well, if it's been around that long, obviously there's some success. Or
It works for some people. It's restricted. Only some specially registered psychiatrists can prescribe it.
Okay.
And as I understand it, they don't really like it because all they're doing is writing prescription heroin prescriptions and don't find it very satisfying. I'm not sure the exact history, but it was a little more available up until the 60s. And the UK government at that time made it a little more restricted. Prior to that, it could be sort of more general practice prescribers that could prescribe it.
Okay.
And some take homes could be possible. Clearly, from that, we shouldn't have to do everything supervised. The Swiss do some take homes, and we started. In 2021, providing take-home syringes to about 11 people at our clinic. And that was as a result of COVID. The pandemic allowed us to relax some of the restrictions. And
how did that work out, even if only anecdotally? How did that work out?
Well, it's not anecdotal. We've published an analysis of the experience of those 11 patients. And their lives improved. They were able to get employment, care for their families. It frees up the time that they have to get on with their lives. Because people's experience of life is nuanced. You know, we're saying if we're saying, oh no, you need to come to the clinic 3 times a day, then it leaves them very little flexibility or to deal with the nuance of their lives. And with that added flexibility, all their lives improved, and we've not had any concerns about diversion. We monitor and check, and those people really are doing very, very well. And we hope to expand that.
So, do those people have to? I don't want to use the term "earn," but I will, just for simplicity. Do they have to earn that level of trust, right, with that supply?
I think yes, but that's not a good enough answer for me as the provider. We need to do better than have just people earn it. And because I think that there's people who are still maybe, like you, for example, using some crack or some stimulant that might benefit from having access to take homes because they want to be able to work or they want to be able to do something else other than come to the clinic 3 times a day. And we need to adapt that, you know, just because somebody's using a stimulant or something, that doesn't mean they can't handle a little bit of take home and the ability to get on with their lives. But I think the most important lens is one of disability. If somebody has a medical condition or an anxiety, so it's hard for them to leave their room, or they're using a wheelchair, and it's hard to get down to a clinic 3 times a day, we should be offering those people alternatives, and the ability to have some carries and take homes. I think that's the lens that we need to use. If people need a treatment, we have an ethical obligation to provide that treatment
in a way that's accessible and
yes,
practical.
I think that's primary. Secondary, if there's some risk of harm to the public or a theoretical risk, then we have an obligation to mitigate that risk. So that could be monitoring, checking that people are doing well on a daily or every 3 days, or checking in on a regular basis, perhaps doing urine drug screens. And I'm not sure this is absolutely necessary, but it's one way to mitigate risk, if to check that people are taking the medication that they're provided, right? And then thirdly,
and I think go ahead. No,
if there's imminent risk, then we have a duty to respond and intervene. But those are all steps, and that's all manageable. Primary is providing care.
Fair enough. Optically, and just from concerned people, right? Diverted supply is a real fear, and a valid fear at that, right? I think anyway. Some of the things that were talked about at CSAM there, that I didn't attend, but Lisa's she's told me about one of the talks that she went to, about a lot of that, that who knows what that really means, but that there seems to be that there may be a lot of the what is the drug? Sorry, the one that's being prescribed en masse. The dillies?
Hydromorphone.
Hydromorph?
Yeah.
Morphone?
Or no, is it no, not dillies. There's another term.
Methadone?
No.
Suboxone?
Sorry. Crap. Or maybe it is dillies. Yeah. No, it is dillies. Yeah.
It is dillies, like the one that Adam Ziegler talked about.
Yeah.
That's
because
dillies.
they're fentanyl users that are being prescribed a drug that's just not enough for them. So it seems to be that there might be a significant amount of that being diverted. The problem with that is who ends up buying those is the next, younger people without severe opioid addiction, and it might be introducing them into a world that they don't know where that ends. But
so I'd like to challenge that a little bit.
Please do, yeah.
Because we've already established earlier in this discussion that there's a ubiquitously available, highly potent, and cheap opioid stimulant supply on the street.
Yes.
And now we've pivoted to terror that somebody might take a very low dose of a pharmaceutical option that's moved from the illicit supply to the street supply.
Okay.
I think there's a disconnect between danger and what the real risk is. Secondarily,
fair enough.
Where is the evidence that this is causing harm?
I think that was the question in that talk at CSAM, and again, I wasn't there, so I'm speaking third or even fourth person.
Yeah, I was there. It's I think it's what happened was a doctor telling a story of two people. Yeah. And I find it purely anecdotal. There's no paper, there's no data. And if you looked into the Reddit and, columnists like Adam Zivo talking about, oh my God, diverted supply. It's not a paper. It's a photograph, and it's not, it's not peer-reviewed article, right? Yeah. And I think it's really easy to get it down inside. side being meth and down being fentanyl, benzo. And there are like, on average, there are 4 dealers every block. It's way easier. I've almost never seen Dilaudid being just working, going into the alleys and doing my outreach. It's way easier to get meth than to get dealies. So I like that point from Scott saying that, okay, well, it's a low dose hydromorphine, and they're, they get an access to that, not as easy as getting an access to fentanyl or carfentanil.
Fair enough. Fair enough. Yeah.
And the real problem is, for me, that the problem of a poisoned drug supply and illicit drug poisonings, which is going to be 2,000 this year in British Columbia, has not been addressed. And we need to have effective treatments that therapies that will get folks that are at risk into care. And hydromorphone tablets is not going to deal with it. So having a discussion about whether a hydromorphone tablet is diverted or not moves us from the real urgent discussion.
Okay.
And there are safe, effective, clinically effective options proven to reduce mortality, like injectable diacetylmorphine and hydromorphone, that are not available and need to be made available. And the poisoning crisis has moved on. Yes, there's still people injecting, but the plurality of folks are now inhaling.
Yeah.
And
yes.
The Netherlands has had an inhalable prescription heroin program for going on 3 decades, with a randomized controlled trial that shows safety and efficacy, decades of experience. We had data from British Columbia Center for Disease Control that people had switched to mostly inhaling in 2017. And a public health emergency had been declared here in British Columbia the year before.
Yes.
Now, if we were treating this in this province and in this country like a real emergency, something would have been done about that. We would have looked, there's a 20 plus years of experience in the Netherlands dealing with exactly the problem that we have here. So we should look at that. And has it been? No.
Absolutely not. No.
We're talking about whether dillies are being diverted, which is totally a non sequitur.
No, it's really it's kind of like I see it like blaming a seatbelt for people who are doing fast driving or racing on the street. Like, should we just get rid of the seatbelt then? Is just let people just do whatever they want? Because I think that's what we are doing here with the concern about diverted dealies. It's like, oh, what if it's diverted? Oh, we should stop prescribing dealies. But like people are dying every single day because of poisoning, because they don't have any access to pharmaceutical grade, medications. So it's really derailing us from the focus that there are on average 5 to 6 people die every day due to this poisoning, and we're thinking about the possibility of diversion. And I found that I actually try to confirm with the people that are conducting, that are making these machine, the Dealey's machine, and they said that this reports like from Reddit is actually inaccurate. Like, this is not accurate at all. It's not an accurate representation, and like we need to address the deaths the way that it is, and we know that in other countries through randomized clinical trials that they work, and ideally we just do that. And why haven't we?
I've got to say, one of the great things about doing this for a living for myself is how often my opinion changes. Right? It goes like, I have been all over the map on all of the big issues, and again now I find myself having a shift as I learn more, and as I'm exposed to more and more people like yourself, Doctor. I like to think I'm becoming more enlightened by the day, right? Because you hear one side of things and you hear another, and then who knows, the next guest might have me disagreeing with you again completely. But I got to say, you're making a hell of a case here, right? And
But
it's something.
but
Yeah,
I'm not opposed to methadone, Suboxone, Cadian, and abstinence-based treatments.
yeah, yeah,
Those are effective. They work for some people, and they are what some people are seeking. All
yeah,
I'm
yeah.
saying is
And
we
well,
need
it's
diversified
one more tool,
options.
right?
We need
Absolutely,
to
and
be
Options.
yeah,
inclusive
yeah,
of the people that aren't ready for those things yet. And
100%. Yeah,
some jurisdictions have been able to accept that. And I think
yeah.
that the Netherlands is probably the furthest along. If this is you might want to speak to somebody named Wim van den Brink, who's a
Wim
professor
van den Broek.
in the Netherlands. He was
Mhm.
the person behind their heroin trials and the inhalable program they have there.
How do you
But
spell that, doctor? If you don't mind.
Wim Van
Yeah.
VANDEN Brink BRINK, and he
Oh, I
talks about
remember.
a program in this their care model has been switched to one of patient preference. So if somebody's looking for abstinence and not to use any drugs at all, there's a referral pathway stream. If you're looking to stop all illicit opioids and have a pharmaceutical alternative, there's a referral path, a care stream. If you want to still use some opioids but have take some methadone or Cadian or something that you've got something to manage withdrawal, but you can still use. There's a referral pathway for you. And if you are still seeking a euphoric effect, a opioid high, so to speak, they have options for you. You can go into your doctor and say, I really need to continue to feel something euphoric in order to get by day to day. And then that physician, that nurse practitioner, can refer you for injectable or inhalable prescription heroin. That,
Wow.
I think, is the real revolution, not from one of what the treatments are, but meeting patients where they're at and
Mhm.
using the tools that are effective for that person because it's what they're seeking. And we know that once people are in care, most will move along that continuum. They'll move on to other things.
So there's got, and I know I'm almost positive there is, and I'm pretty sure you're going to have some sort of cost benefit to that, like just from financially. I know there is studies that have been done. Can you speak to any of those as far as what the taxpayers that are about the money and how these things affect things that way?
Yeah, I think that's a good point. And this shouldn't be a partisan discussion. But if
Yeah.
somebody's approaching this from the sort of right of center or left of center, we've got answers to satisfy on both sides.
Okay.
This providing prescription heroin by injection is cost effective. It reduces
Okay.
the burden on the taxpayer. The bulk of that savings is in the criminal justice system. And
Yeah.
on average, over a lifetime, one well over $100,000 savings per person that started on injectable, mostly with savings in the criminal justice system.
Okay.
And it
Okay.
also reduces crime,
Yeah.
both property
Right.
crime and
Right. Yeah.
violent crime. Uh,
Yeah.
Because they're
Yeah.
not desperate anymore. I think
Yeah.
the reason why people starting committing some of the crimes is because they're very desperate.
Oh,
What if
100%.
they're not?
Yeah.
Yeah, if
Right.
they're not
Yeah.
very desperate anymore and they know they can get uh, a safe high, then there's no really a reason to engage in these criminal activities.
Yeah. Right. Right. So the societal benefits past the taxpayer dollar are well,
yes.
that never ends really.
Now, should we find ways to bring costs down, make it more scalable, more cost effective? Absolutely, but we're not even
But
having
that
those.
starts when you start introducing it at all, right? Once it's
It,
done en masse, anything gets cheaper,
exactly.
right? Right.
Like
Yeah.
currently, we're
Yeah.
providing they need to be compounded in a solution, and that's cumbersome and costly, but still cost effective. What the British are doing with the take home a powder, that's much less costly. So there's something that that could be looked at. We recently published a paper on reduction in crime. We were able to have access to direct Vancouver Police Department files. So we yet again evidence that providing injectable rather than continuing methadone reduces crime. The cautionary tale there, though, was we didn't reduce victimization of women or people who identify as women.
Okay, explain that.
Well, I think that people who are female and come to our clinic, firstly, they tend to be a little bit younger, and our clinic is mostly male and mostly older. I'm not sure that's going to feel like a safe place for female patients.
Yeah.
Plus, they need to come out on the street. We're in the center of the downtown at Hastings and Columbia. It's rough, and I think some people don't want it, especially if you're female involved. You might not feel safe out there after dark.
Yeah, well, that's a true story.
After dark.
So we need to find ways that are more flexible to make people feel comfortable accessing care and safe, and that might mean delivering treatment to their building, or having small mobile clinics that will go out to people's housings. And the Portuguese have figured this out. That's part of the Portugal model. Or if people are on an established dose that's safe and effective, rather than coming to a clinic that requires them to come to an area that might feel unsafe to them, go to your regular pharmacy and get it, one that's around the corner from you.
Yeah, right. These are amazing conversations, Jack.
I know, right?
Yeah, I'm good.
That's why I invited Scott.
I'm trying to get used to the vape again. The smoking is, I'm trying to give it up and get back to vaping, and then I'll eventually give that up too. So it's, right.
Well, it's harm reduction, right, Chuck? I mean,
I was doing really good too, and then I fell off and grabbed a couple packs of smokes. Shit! So here we go again.
It's more sustainable to make small incremental changes than
Hey,
it's
not a crack pipe. So, there's that.
It's
right?
not a crack pipe. From cigarette to basically vaping to basically,
right. So, it's for me. It's kind of frustrating. The first time I picked up a vape was years ago. In they weren't legal then, right? And I went from 2 packs a day to like feeling better than I have ever, like as an adult. And then when my life fell apart, I kind of gave it all up. I went from buying these vapes to owning 4 vape shops in a year. Right? I was so passionate about it. Oh yeah, it was crazy. It was at 4 vape shops in 4 cities in a year, right? And it went nuts. But then, whatever, that didn't end well. It ended in a divorce, actually, is what it ended in. So I got back into smoking, and then just recently tried the vaping again. So it just doesn't seem conducive to living a healthier life like I'm trying to do here, right? Have a cigarette and then go do yoga. It just seems silly. The whole damn thing is silly. So,
but
hey, listen.
Go ahead. The smoking's a good analogy, though. Here in North America,
it really is. Yeah.
The danger from cigarettes is in the smoke, not in the nicotine. And if you want to reduce your cigarette use, you can go to a pharmacy and buy nicotine inhalers, nicotine gum, nicotine lozenges, nicotine patches. You can get your if you want to do the vape, you can do that, and there's other pharmaceuticals, and it's patient choice what they can take, and why it should. I think it could be the same for other substances that are currently illicit. More pharmaceuticals, more routes of administration, more patient choice.
It's a great analogy. It really is, right? So
I'm curious about in the background we would talk about this, Scott, but people love meth, speed, right? Side. And what's the options that we've been seeing for people with this approach in Europe, for people who like meth?
There is extensive evidence that prescription stimulants are helpful, safe, and effective. The first clinical trial that's relevant for me was out of the Dutch heroin-assisted treatment program, published in the Lancet in 2016, prescribing dextrogen, a sort of extended-release dextroamphetamine product that for people that were using crack cocaine or other stimulants. And if in that randomized control trial, the group that received the dextrogen used less stimulants, more likely to leave urine drug screens without any stimulants in them, and in the secondary analysis, their function improved. So based on that analysis, we started prescribing dextrogen at our clinic because it's exactly the same population, and it helps many people. It's not 90%. It's probably in our experience, it's probably more like 20 or 30% of folks that try it find it effective.
But it's important for people. I'll interrupt you real quick if you don't mind. It's important for people to understand 20 to 30% effective in the addiction world is massive, right? Like that's a huge win relative to, you know, so many other ways that we're trying to treat things right now, right? So I think it's important to acknowledge that 20-30% is, you know, it's a big deal, right? You know,
yeah, and for the folks that it works for, you know, they can use less, they can focus, and you know, some of them are working now. So you know, I've seen it have you know, effects on people's lives. There's a lot of overlap between stimulant use and ADHD, attention deficit hyperactivity disorder.
That one's dear to my heart, and I can tell you from my personal experience, I had no idea for my whole adult life that I had ADHD until I quit using stimulants. And it was a friend of mine's wife said, well, yeah, right. Look at you. Of course you do, right? You were medicated for this, like self-medicating for all these years. And now you're a mess. And to me, I've spoke to this a few times on the show. I almost wish I never had that conversation with her, because what ended up happening is I'd moved from Saskatchewan to Alberta, ID, all of it. Like it was a real challenge going from being homeless to being a productive member of society. No, you know, I didn't have ID, getting my healthcare squared away, go see a doctor, try and get medicated, try and get diagnosed. All those things turned out to be a real challenge. And as I sat there in my brain's chaos, right, and what I describe ADHD as being pissed off at yourself 25 times a day, all the time, being angry at yourself, and the self-talk that goes with that, right? It's funny. Like I laugh at the TikTok videos with everybody else about, you know, ADHD, but then when it's all said and done, it's like I wonder what it'd be like not to be mad at myself all the time, because I am, like, all the time. And I said to Lisa, $40 in a phone call, and it goes away, right? That's all. So it's the closest I've come to relapse is because of ADHD. Right, hands down. It's just like I could just make this chaos go away for a day if I just, you know, $40 in a phone call. Right, I just got to call up somebody, get myself some meth or coke or whatever, and go back to that feeling of center right before the chaos completely takes over my life and runs it into the ground again. Right, but I'll tell you, it was a really hard thing to do. So yeah, there's some overlap there, and that's only, you know, it's my personal experience, but. Ooh, right? It's been tough for me, right? So yeah.
So there's a group led by somebody named Tardelli, who published a meta-analysis of the effectiveness of prescribed stimulants for stimulant use disorder, and that a paper that I thought was interesting that came out in the spring of this year. Sweden has been did a cohort analysis, provided a long-acting medication version of dextroamphetamine called lisdexamphetamine, which is also a treatment for ADHD. But they provided to about 13,000 people using methamphetamine, huge cohort. And in that analysis, the people that received dextrogen had less hospital admissions and reduced mortality compared to not prescribing. So There are pharmaceutical agents that are clinically effective and can reduce mortality and hospitalizations, and we need to be looking at expanding access to those. We're fortunate in British Columbia. Is as part of our risk mitigation guidance for the pandemic, included dextrogen and methylphenidate, Ritalin, as options for people that want to reduce their dependence on street stimulants. So those continue to be options with guidance from our sort of clinical leadership here in British Columbia. But as far as I know, that's the only jurisdiction in North America that has prescription stimulants as an option for people that are using stimulants. And that's given the evidence, I think it's a dereliction of responsibility that we're not supporting prescribers in other parts of North America to meet the needs of patients who are at risk.
So before we move into the final segment of the Daily Gratitudes, personally, and this is opinion, I mean, well, maybe it is opinion, but do you feel that we are making progress as a society in North America, or do you feel that we've come up on a wall? Where are you at with that?
Well, we're making progress in terms of a few pilot programs, and ideas are germinating, but nothing's been scaled up. There's been no population level willingness to expand anything or try anything, and the number of deaths is either unchanged, the death rate hasn't changed, or it's gone up. And if you just need to compare us with some other jurisdictions in the world that have similar opioid prescribing rates, that have no illicit drug poisoning crisis, that have diverse options for care, that have sort of a patient-centered and patient choice approaches. So while I'm, there's lots of ideas here in North America, and I'm grateful for that. The willingness to actually act is lacking.
Okay. So are you optimistic? I guess is what I was asking. Are you optimistic about the future? Or
we just need one person in a leadership position, elected official, who's willing to step out and say, this is what we need to do, and we could have systemic change. I'm hopeful that that person is just around the corner.
I like that. I do. Okay. Well, I'd like to thank you for giving us your time today, Doctor. This has been a great conversation. I'm really happy and that Attica connected you to the show here, and that you're able to come on. I would expect another invite down the road. Right? So I think Dr. Lisa would love to have a conversation with you as well. It's unfortunate she's on holidays. She's in Disneyland with her family right now, and I'm glad that she got to take that time away. But I don't. Do you know about Dr. Lisa, who she is, or relative?
I haven't met her. So maybe I will someday.
Her heart is huge. Go ahead, Attica, if you want to do the honors and explain.
So at CSAM, me and Dr. Lisa were there, but Scott wasn't there. So you were doing a talk in Montreal, right, Scott?
Yeah, I did go to CSAM this year.
Dr. Lisa is a psychiatrist who specializes in addiction, right? Her brother is 23 years in active addiction. So she actually quit her job as an oil field engineer to go back to school, become a psychiatrist, so she could further understand her brother's struggle. And we crossed paths in the very early days of the show. I'm not a religious person, but sometimes I think that was divine intervention, because her lived experience combined with her professional experience combined with who she is as a person has just brought her into my life. The lens that she views things is 1 in 10 million. She's just this amazing human being, and she comes on the show, and she's one of my Weekend Ramble co-hosts, along with Attica here now, right? As long as she doesn't keep making those age cracks. But she's absolutely amazing, and she's brought in some great guests, just as Attica has as well. Dr. Rob Tanguay, I'm sure you know. Dr. Ghosh, Monty Ghosh as well, is came along through her. It's just been a blessing to the show, and it's taken us to the next level. Right? So, and you're on that list now of esteemed guests that we've had on, and I'm really grateful to have you on the show. So,
thank you.
That takes us to my favorite part of the show, and that is the daily gratitudes.
Today's Daily Gratitudes are brought to you by Revolution Recovery, helping men recover and become their best selves through support and treatment. They've been there and they understand.
We start with you, Dr. Scott MacDonald. What are you grateful for today?
Today, I'm grateful for the rain here in Vancouver. I'm going to have a cozy day inside, and I'm grateful for the blanket that I have here. It's despite the cold and wet outside, it's cozy and warm and very comfortable where I am at, and I'm grateful for that.
I love that. I love that. Attica, what you got for us?
I'm grateful for the blanket as well. I already have it here. Go back to sleep after this. But yeah, I'm going to be cheesy as always. Grateful to have another amazing talk at this podcast. I know I've missed a few episodes because I was so under the weather. I'm so grateful I don't have a tension headache anymore. And I'm grateful at the people in the alleys and on the streets that given me a lot of wisdom and allow me to understand what it's like.
That's audacious. To given me a lot of wisdom, she says, right? Oh, well.
Yes, audacious. So yeah, I'm grateful for that.
For myself, I am grateful for being in Thailand and all of the things that have happened here. I'm grateful to have completed my 30-day stay here at the Yatra Center and given the chance to address some trauma and get some tools and to be living in the most amazing place I've ever even considered that I might live in. This is incredible here. I am grateful for your time, Dr. Scott, and yourself, of course, Attica, for showing up after a couple of weeks of not being able to. I am grateful for the faith. And last and certainly not least, I'm grateful to every single person who continues to watch, listen, and support. Whatever you guys are doing, please keep doing it. This is working. The show continues to grow. We're doing a good job. Like, comment, share on the social media stuff, guys. I really do need to help with that. Anytime you do any one of these things, you're getting me a little bit closer to living my best life. My best life is to make a humble living, spreading the message. The message is this. If you're in active addiction right now, today could be the day. Today could be the day that you start a lifelong journey. Reach out to a friend, reach out to a family member, call into detox, go to a meeting. I don't really care. Do whatever it is you got to do to get that journey started, because it is so much better than the alternative. And if you have a loved one who's suffering an addiction right now, just taking the time to listen to the Weekend Ramble, if you could just take one more minute out of your day and text that person, let them know they are loved. Use the words.
You are loved.
That little glimmer of hope just might be the thing that brings it back. Oh, there we go.
My body's getting cold. My life is running low. Feel me falling. My life is running out. I pray I make it now. But if I don't, it will be okay. I'll find you another day, and I'm not scared to go. It will be okay. I'll find you another way, and I'm not scared to go, because when I die, I'll be happier in another life. I'll be a ladybug soaring through the sky.